Good morning, everyone. Welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for another session, and thank you for spending part of your weekend with us. My name is Jackie Sable. I'm part of the Echo team, and I'll be facilitating today's session. A few quick announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you're speaking. If you're dialing in, you can use *6 on your phone to mute and unmute, or if you're on a computer, you can use the microphone button on the bottom left-hand side of your Zoom screen. You can also use the chat for communicating during the session. We realize question and answer time is important to you, and we are trying to categorize and address as many questions as possible, but if anything is left open, we'll follow up in an email afterwards. If you have suggestions for future COVID-19 ECHO topics, please share via the chat tool, or you can email us at echo@psu.edu. Please remember that no personally identifiable information is allowed. We are recording these sessions, and we share both the recordings and all materials afterwards. In the spirit of all teach, all learn, we'll be on a first name basis during sessions. We're thrilled to have Dr. Gavin Macgregor-Skinner back with us today. Our session will include a lecture by Gavin on recommendations for crisis standards of care and decisions facing healthcare workers in allocating scarce resources for COVID-19. And we'll follow that with a question and answer time. During the lecture, please feel free to put your questions into the chat. We have a team of specialists from Penn State Online. They'll help to field questions, but please remember that this is an all teach, all learn environment, so anyone can share both questions and answers. And with that, I am going to turn things over to Gavin for our lecture.
Thank you, Jackie. Hi, everyone. So today I'm going to give you some recommendations only. I'm going to talk to you about crisis standards of care, decisions facing healthcare workers in allocating scarce resources for COVID-19. The purpose of this lecture is to create awareness of some of those issues that are challenging the healthcare industry with regard to the subject of crisis standards of care for disasters. The material presented is in no way meant to provide answers or absolutes as to what crisis standards of care are appropriate for use by any organisation or for any specific event. Crisis standards of care defining elements. Crisis standards of care is a substantial change in usual healthcare operations and the level of care it is possible to deliver, justified by specific circumstances. It's formally declared by a state government in recognition that crisis operations will be in effect for a sustained period. Emergency declarations are essential to the implementation of crisis standards of care in any jurisdiction. We need to understand what is the continuum of care that we deal with. Conventional care is normal care. Services are provided by healthcare during normal times, routine, on a daily basis. That moves to then contingency care, where we're stressed, but still functional, and we can expand by being creative. And then we go to crisis care, where the resources are scarce. Care methods will change. Optimal care is challenged. And our care is provided to populations of patients as a whole because these limited resources are available. Methods and locations of care delivery shifts from patient to population-based outcomes. Crisis standards of care, the fundamental concept that I want everyone to understand is medical surge planning, along the lines of the concepts of the continuum of care, conventional, contingency, and crisis. The Institute of Medicine reports that are listed below are the fundamental documents and guidance developed for crisis of standards of care that have occurred since 2007, medical surge capacity and capability, all the way up to 2013, where there was a toolkit for developing indicators and triggers for crisis standards of care. And many other publications have been published since then to support the implementation, the planning, and the operation of crisis standards of care. So what are crisis standards of care? Crisis standards of care is a state of being that indicates and I want this to be very clear, indicates a substantial change in healthcare operations and the level of care that can be delivered in a public health emergency justified by specific circumstances. Crisis standards of care are not optimal care, but they're forced choices based on an emerging or sustained event in which the capacity and capability of the healthcare facility has been exceeded and resources are scarce. The criteria for crisis standards of care should have a strong ethical grounding, have integrated and ongoing community and provider engagement, education and communication, have a legal authority and a legal environment in which crisis standards of care can be ethically and optimally implemented, have defined clear indicators, triggers and lines of responsibility delineated, and they must be based on evidence-based clinical processes and operations. The multifaceted issues of crisis standards of care include legal, ethical, moral, and medical. And often when we start talking about crisis of standards of care, and when I teach disaster medicine in crisis standards of care, so many people get caught up in that it's only a legal issue or it's only an ethical issue. No, it's all four. It's legal, ethical, moral, and medical issues that we need to deal with. The two primary triggers for implementation of crisis standards of care include: one, capacity and capability, what we can do in our hospitals, nursing homes, and other institutions. Two, the size and duration of the event. And the resource deficits of an increased need for supplies can lead to no other choice situations, as we've seen in some hospitals and some facilities, nursing homes as well, with the COVID-19 patients that we're receiving now. And this can include, the resource problems can include inadequate stuff, inadequate space, inadequate staff, and inadequate finances. But there are also other issues, and there are other issues that we're dealing with under COVID-19 as well, such as altered standards for documentation, legal, accreditation, quality, reimbursement, paper versus electronic. And as you listen today, and I want you to think, where you work right now, what would you consider to be the essential documentation that you need right now to keep your facility functioning, your hospital functioning, as you get a surge of COVID-19 patients? And there's also key elements that I need you to consider for crisis standards of care within a framework, which it considers, ethical considerations, community and provider engagement, legal authority and environment, indicators for assessment, potential management, and triggers for action. All those Institute of Medicine documents that I presented have so much information under these subheadings for us to think about, for us to plan and then implement crisis standards of care successfully. But the challenge that we have for every disaster, and especially now for COVID-19, was that we tried, or we thought we would try, to avoid the paper plan syndrome. But what we're seeing in reality right now, both at the federal, state, and also at the local level, but also at our facility level, is this overwhelming production of paper documents with guidelines, standard operation procedures. And it's just too much. It's overwhelming, and no one has the time to go through all those paper documents. But this is not the first time we've been dealt with a plethora of paper documents and worked out what to do next. As we, in 2014, when we were preparing hospitals throughout the country for possible Ebola patients, we were dealing with a complexity, a cascade of just a production of guidelines, recommendations, standard operating procedures that were all paper-based. Our plans were hundreds of pages and were paper-based, and it was confusing of what to do next. And so what I wanted to present to you in this slide is that planning, operationalizing, implementing crisis standards of care can be done with a simple table such as this one. This table shows that when you can identify the indicators, the triggers, the tactics developed across crisis standards of care, the continuum of care for surveillance data, the staff, the space, the stuff. We focus on contingency, crisis, including within this table what those indicators will be for when we have to make decisions, what those triggers will be, and then we outline what our tactics will be. And instead of producing 30 or 50-page documents, we're producing simple tables like this, which helps us in our critical decision making. So what can be done to prevent or minimize bad outcomes? Developing protocols for adapting or implementing crisis standards of care. Again, ensuring that we're not producing lots and lots of pages of documents, but focusing on tables, decision matrices and trees, and other tools that we can use to help make decisions for emergency departments. Mass casualty, as we look at crisis standards of care protocols, helping the staff understand what our principles of triage are. Looking at ventilators and oxygen protocols on the allocation of those scarce resources. Allocations of other scarce resources, and looking at alternate care sites, both for diagnosis and sampling of samples for lab tests, but also alternate care sites for treatment and care, and have those sites pre-identified. And then when we think about how do we define, when, and how to implement those crisis of standards of care, we determine when to implement and which measures are appropriate at the conventional, contingency, and crisis stages of care based on indicators, based on triggers or decision points that are based on the availability of resources. We look at the crisis care trigger itself as we move from contingency to a crisis. What's that transition from contingency care to crisis care? At the point when resource allocation focuses on the population rather than the individual patient. What are those tactics that we have to use that are both scripted, predefined action or set of actions, which are understood and can be implemented quickly by all staff? But also, what are the non-scripted tactics, which may vary according to the situation based on multiple inputs tailored to a specific situation? Most of us right now have transitioned from a paper plan to a response. And I want to remind everyone that plans are nothing. It's planning is everything. It's bringing those people together to talk about the situation, the status, the complex challenges that we have, and how do we develop a plan to respond to complex problems and situations when we are finding that resources are scarce. And I want to emphasize that you alone will not be able to do it all. If you haven't started already, this is the time right now to create partnerships, to make friends. It's about crisis standards of care implementation focuses on fostering a culture of collaboration. And collaboration is a process where people or organizations of different perspectives come together to solve a shared problem with a common goal. And it takes many partners to focus on that one mission. Right now, providing the standards of care that are required for COVID-19 patients. As we both work with both government, non-government, federal, state, and local organizations. It requires a team to make this work. But even now, with what we've been dealing with over the last few weeks and now coming up to months, many of us are suffering from emergency preparedness and response fatigue. It's a known problem. It will continue. It will deteriorate. It will get worsened. And this is why the emphasis I'm putting on right now is for collaboration and teamwork. Because crisis standards of care implementation is all about surge planning. And that surge planning process provides those opportunities for collaboration across many sectors, especially within hospitals and healthcare, of many sectors that we may not have traditionally worked with. And one of the primary goals of crisis standards of care implementation is to stay out of the crisis phase by using incident management to be a proactive rather than a reactive approach as early as possible during an event. And I'll give you an example. When Craig Fugate was the FEMA director, he introduced the Waffle House Index. The index is more of a measure of infrastructure status. It's the availability of generators or grid electricity or of clean water, for instance. It's a measure of infrastructure status more than it's a measure of disaster itself. And at all the Waffle House restaurants throughout the country, the public could access maps like this, which showed the Waffle House Index. And for example, on this map here, it shows that there's 365 Waffle House restaurants that are closed and 1,627 are open. But we haven't taken this approach for healthcare, for hospitals, for clinics, laboratories and nursing homes and other institutions that we work with. And we need to start understanding that that may be an approach we should be looking at as we start to conceptualize what does the systems framework look like, or what exists right now for implementing crisis standards of care. As it starts from federal government, goes down to local state government, right down to the performance improvement, our implementation, our community and provider engagement, as well as ethical considerations, legal authority and environment, and as well as that just-in-time training and education, and more importantly, the information sharing. There's so much resources, information that we have now that we need to be able to share within our healthcare care system, as well as our wider community. So within the documents that I showed that have been issued by the Institute of Medicine and many other documents that are available both at the state and local level, they address staff issues for altered standards of care, staffing considerations, and personal information. Space issues, and again, looking at alternate care sites, but also space issues within your existing hospital facility, and and understanding that we do know what we have, and we do know what our limitations should and can be and will be in times of surge of patients. And it's also when we have issues where we have to double up in rooms, but also move people out of the traditional areas where we would treat and care for them into other areas of our hospitals. And then the staff issues. And again, these are well listed of the issues, the areas that you should be focusing on, from the inventory of critical supplies, which is something I see really a big gap for us right now. That just-in-time delivery that we're looking for the supply chains, the way that we're coordinating our stocks, the way that we're counting our numbers of what we have and understanding what we don't have. And that as we move from into contingency care, we adapt the stuff that we have. But as we move towards crisis care, it's about allocation. And if we look at the stuff, let's focus on the stuff for contingency or even crisis standards of care planning. Let's look at the routine use of equipment that we have for treating patients that have pneumonia, have breathing challenges, or other situations where we may have to use ventilators, IV pumps, specialty beds, wall suction, IVs, monitors, or any other medicines or pharmaceuticals. And look at what the options we have available, both right now in our facilities, but also where we might be able to procure from other sources. And then as we move towards contingency and then into, if we have to go to crisis standards of care, we are looking at lower tech solutions that may be required, but they will not meet the normal standard of care. There's also money issues, where we may not have enough cash reserved to pay for things, or that we're unable to make payrolls, or just through planning, where we are challenged with regarding making payments. And so some of these other issues, other than staff, space, and stuff, will be these altered standards of documentation, the legal, the accreditation, the quality, the reimbursement, paper versus electronic. And again, I want to challenge you right now, what would you consider to be the essential documentation that you need in your hospital, your nursing home, or facility to continue operations under a crisis of standards care situation? And there are systems that exist that can support the crisis standards of care in addition to the 3 S's, the staff, the space, the stuff. And those systems are required for active real-time monitoring, establishing and maintaining situational awareness and information access, the internal and external communication with redundancy, but also the metrics that we need to provide a feedback loop, to provide benchmarks, indicators to assist with our decision making. And as we look at those allocation of resources across the continuum of care, from conventional, contingency to crisis, if you haven't done this by now, then you need to start looking at what are the triggers, what are the decision points to go from conventional to contingency. What is the decision points for moving from contingency to crisis standards of care? The COVID-19 impact on conventional standards of care, and this is what we know right now, we are seeing here in the US at the local level insufficient hospital beds, both general and ICU. We are seeing where we have insufficient healthcare workforce. In some local areas, we're seeing a large number of patients seeking care. Regional hospital bed availability and surge capacity. We're looking at this within our hospital region, looking at where that hospitals may not have sufficient resources, staff, and space. How do we transport those patients to other hospitals that may be able to assist? And it's important within the clinical framework of why are we thinking this for COVID-19? Because it's from what we're learning right now, that the number of patients have and are likely to exceed our healthcare infrastructure capability to provide conventional standards of care. And we know repeatedly every day the supplies of medical countermeasures, personal protection equipment, as well as ventilators and other vital medical equipment may be inadequate. And for the COVID-19 hospitalisation criteria, we do know there's no national standardised approach to hospital surge issues due to the local variability in our capabilities in our hospitals. But we do know that we need expert judgment. And we do know that we need to set up teams and committees to ensure that we can focus on the local and regional hospital admission criteria and determine what we need to do and adjust as events unfold. Within that hospitalisation policy infrastructure, we look at state and regional advisory committees. Within your own hospital, if you haven't done it now, you should have set up a triage team, a clinical care committee, maybe a palliative care team, and also an ethics committee. And I'm seeing lots of hospitals now that have actually started and have set up a separate ethics committee as well as separate triage teams. Our crisis response plans and protocols, even for COVID-19, require much better situational awareness. We need to know what we have internally and external to the facility, the hospitals within our region. We need to know what the indicators are being used locally within our hospital region, as well as the triggers at different facilities and different hospitals. And we need to know the process and tactics for response in real time. What I'm trying to emphasize is we need to collaborate and share. For those that have hospitals that have had to go to crisis centers of care, what are those lessons learned and how do we share those lessons learned with others? We need to focus first on indicators and triggers, as I've mentioned, from the shift from conventional to contingency standards. We then next to focus on the tactics to mitigate these factors to prevent us shifting to a crisis response. And with those crisis response plans that I'm hoping that many of you have already started and were working on, it focuses on that resource scarcity. It's the basis for the shifting that may be limited from conventional to contingency to crisis, but understand that it may be only one aspect of patient care requirements that causes this trigger point, this need to make these critical decisions. And again, I want to go back to the paradigm that COVID-19 is all about the numbers. The numbers we see each day in the media are real people. The cases are real people. The deaths are real people. People with real names, with real families. They're not just numbers. But the numbers we need at our hospital, our nursing home facilities to plan for a crisis of care situation are also available. And we need to make them better available on a more regular basis, daily, twice a day, but so that everyone understands what we have. And if I give you an example right now for something for you to think about, if 2 in 10 adults are infected where you work, would your hospital be at risk of being overwhelmed by COVID-19 patients? That's if 2 out of every 10 adults in your catchment area. And if we look at what was published yesterday in the Washington Post, and we took that question, if 2 out of every adults came down with COVID-19, we would have about 17 million adults, or 6.5% of the US adult population, live in communities where COVID-19 patients could overwhelm hospital beds, needing more than all are available. 76 million adults, or 30% of the US adult population, live where patients could overwhelm intensive care beds. 125 million adults, or 48% of the US adult population, live where virus patients could overwhelm the supply of mechanical ventilators. And that's a modeling situation based on if 2 out of every 10 adults were infected with COVID-19. There's also another resource, and there's many resources out there locally through different media outlets, universities, and other organizations. And this particular one came from the Washington Post, where are your hospitals at risk of being overwhelmed by COVID-19 patients? And you can enter your zip code or your hospital region. There are 306 hospital regions across the country that are made up of multiple zip codes that regularly cross county and state lines. And making these resources available to the public, to everyone in the US, helps them understand why we're asking them to do the physical distancing, the social distancing, why we're asking to take these measures that are causing, again, so much other suffering, both emotional and financial, throughout our communities, because these types of tools that are available show what happens with only 2 out of every 10 adults being infected. So again, if 2 out of 10 adults are infected, would your hospital be at risk of being overwhelmed by COVID-19 patients? And just where I live, in the Arlington Hospital region, Washington, DC, Tacoma Park, Baltimore, if we looked at this of what available beds, ICU beds, or mechanical ventilators are available, every hospital region either said maybe or yes, we needed more. And again, in the local region where I live here in Washington, DC, the hospital referral regions, again, there's 306 across the country. And these are numbers that we know that we need to share. And here in this map, it shows the number of available beds at each hospital within the area, whether it be Arlington, Washington, DC, Tacoma Park, or Baltimore. And again, for years within hospitals and the healthcare system, we've kept these numbers quite secretive. But this is the time now where the population, the public, need to understand resources are limited. And the resources that are limited are real numbers. And this is what they look like. But again, when we start revealing real numbers, we also see wide variations. And this is a graph that shows the differences between Seattle, Iowa City, Owensboro, Lubbock, in critical care physicians, critical care nurse practitioners, hospital beds per 100,000 people, ICU beds per 100,000 people, mechanical ventilators used per 100,000 people, So as we understand the triggers for going from conventional to contingency to crisis standards, as it relates to what resources are available, these are real numbers that we know that we have to put on paper and start analysing and interpreting and developing those plans and those triggers for what we do when they become scarce. And here's an analysis that was done by the Johns Hopkins Center for Health Security on Thursday, April 8th of this week, which showed the incremental need for a single 100-day COVID-19 wave. Now, this was assuming that we maintained our existing social distancing, our physical distance, and they've rounded to the nearest million what we would require over 100 days for gloves, isolation gowns, medical grade masks, or N95 or similar disposable respirators. And the numbers we need are staggering. But what they didn't include in their analysis, and I hope they will soon, is the use of powered air purifying respirators or PAPRs, the plastic face shields that we're all wearing, the eye protection, as well as footwear. How many photos have I seen in the media where staff are working with COVID-19 patients and they're wearing normal day footwear? They're wearing the shoes that they wear to the hospital that they'll most likely wear home as well. So again, as we start to do these modelling numbers, these projections of what we need to understand there are other things that we're using on the front line to treat and care COVID-19 patients. Again, we could look at allocating other scarce resources such as ventilators and oxygen. And right now, I want to emphasize that all of you should be reviewing your ventilator protocols. You should be considering options for maximizing oxygen delivery capabilities. You should be planning for those possible difficult scenarios, whether they happen or not. And you should be looking at your protocols for allocating resources. Have you at your facility, in your hospital, in your nursing home, wherever you work, have you made those decision-making processes known in place in the event that demand is greater than the number of equipment supplies available? What does equitable allocation look like? How big of an issue is it, and how are you going to deal with it? I want to start focusing on what we're seeing within many hospitals and nursing homes right now is these establishment of ethical teams as well as triage teams, where we're looking at how to do the fair allocation of scarce medical resources. We're classifying patients based on their care, based on the severity of their illness in context of the resources that are available, with the goal of doing the most good for the greatest number of people. That's what our patient surge triage does. This is what I teach in disaster medicine. This is what we do for a natural disaster, be it an earthquake, a tsunami, or a hurricane. But it's also what we do when we have high infectious disease outbreaks like Ebola and COVID-19. Many facilities, many hospitals, nursing homes have already implemented their incident management team, their incident command system. And your hospital incident management team may look something like this. But we're now starting to add these ethical teams. Where do they go into your incident command system? Where does the triage officer sit? Where does the triage team sit, which may be subject matter experts as well as members of the community? And how does that fit into the existing framework that you have for your incident management system team? Because those triage teams that I'm seeing formed at some hospitals, some nursing homes that need to be done more, consist of a local group of technical experts, clinicians, facility administrators, clergy, community leaders. They use predefined triggers to shift the standards of care. They guide the healthcare facilities to share resources to meet local needs fairly and equitable. They develop, modify, and adapt the existing guidance or policy. And those triage teams, as they establish their triage criteria, they define the hospital admission criteria. It could be done locally and regionally. In situations of contingency or crisis standards of care, the highest priority is given to patients most likely to benefit from the available treatment based on the available resources that we have. We need to ensure the availability of resources are used to provide the greatest overall population benefit. And as we develop triage algorithms, there are triage algorithms that are already being developed for us as we try to apply those and implement those within our hospitals. They are to be used only after a predetermined trigger has defined a need to shift away from conventional standards of care. They may apply to only one specific aspect of clinical management, and they're focused on clinical treatment of symptomatic patients needing hospital care. And there are triage decision tools that have been out for many years, but understand that as they focus on limited resource allocation algorithms, it might be ventilators, there's tools such as SOFA, the Sequential Organ Failure Assessment Score, ESI, the Emergency Severity Index, START, the Simple Triage and Rapid Transport, or Jumpstart, the pediatric version of START, and there are many, many others. But you need to recognize the limitations of these triage tools. It's not about assigning a prognosis. All the tools have limitations, and I want to focus just right now on one particular tool that is in many states have included the Sequential Organ Failure Assessment Score, or SOFA, in their crisis standards of care as an element of the triage framework for scarce resources. I want to emphasize the clinical utility of SOFA in daily practice is still unproven. Now, SOFA, or the Sequential Organ Failure Assessment Score, can be used to compare patients requiring the same resource, but not necessarily to choose one over the other with regards to the likelihood of survival. The concern that we have about SOFA comes from the 2009 H1N1 pandemic, where it did not accurately predict mortality when used for patients with isolated respiratory failure. But we do know, when we've used SOFA, if there's a large difference between patients with a general prognosis, where patient may have a score of 2 versus patient that has a score of 11, it may correlate with general prognosis. And I want to emphasize that any triage tool, such as the Sequential Organ Failure Assessment Score, or SOFA, fits into a comparative framework and needs to be included with many other considerations. And if you haven't seen what the Sequential Organ Failure Assessment, or SOFA score table looks like, it's this, where we actually have metrics, measurements, indicators that provide a score to the individual patient that we then add up to give a total score. And if we look at crisis standards of care at the state level, the planning guidance for COVID-19 pandemic, the Commonwealth of Massachusetts released theirs on April the 7th, and that includes within their planning guidance the SOFA score. And also the interim Pennsylvania crisis standards of care for pandemic guidelines was released on March 22nd, and that also includes the SOFA score. But what we're seeing as each state starts to release their crisis standards of care for COVID-19, those documents can vary from anywhere from 7 pages to 80 pages to 120 pages. So it's important now that as we deal with the critical issues of fair allocation of resources, as we look at how to triage patients and make critical decisions, that we come up with some sort of approach to share the experiences that we've had with these crisis standards of care guidelines and help each other understand and how we've implemented them successfully. But also, I want to get back to the numbers. The Pennsylvania Crisis Standards of Care guidance was put together by a bunch of really smart people, and they did it very, very quickly, ahead of schedule. They also produced a map of 154 general acute care hospitals. And this is information that's known. But what's more important is we need to know the staff, the space, the staff numbers in those hospitals. And we need to have them updated because not only are we treating COVID-19 patients, but we're also treating everyone else right now. And treating everyone else right now is using valuable resources. So some of the key points I want to leave you with under crisis standards of care. The most important thing you should be doing right now is develop a process for decision making, the role of the facility agency, how crisis decisions will be made, when subject matter experts will be involved, how the transitions in your hospital, in your nursing home will go from conventional to contingency and to crisis, and then back again, and how they'll be managed. If you have a crisis standards of care plan in your facility, do the healthcare administrators and providers, does everyone know about the plan? Does everyone understand how the plan will be implemented? Does everyone understand the plan provides the policy, the logistical, the ethical, and the legal support for our clinical efforts? Because what happens when you don't have enough? Staff, space, stuff, and money. And if you haven't started making those plans, making those triggers, identifying how to make decisions, then now is the time to start. As we look at how to implement those crisis standards of care, well, when we have scarce resource allocations and we want to be fair and equitable, we need to set those into play by a clearly designated authority. They need to be guided by clear and measurable criteria. They need to be established in advance, but they also need to be flexible as the event unfolds, and they need to be open for public and professional input. And only a week ago, when I started looking and started having meetings under crisis standards of care needs, a lot of local state departments, health departments down at the community level, hospitals, were making their crisis standards of care public. But then there was some criticism, and that will happen from a few in the community. And some of those crisis standards of care plans that I had access to a week ago, I no longer have access. I'd hope to emphasize and to reinforce with everyone, that's not the way to do it. These are tough decisions that require teams, committees to get together to ensure that we meet the challenges we're going to face. I also want to emphasize that hope is not an effective management strategy. And in closing, the more prepared you are, the less vulnerable you will be. And again, April 3rd for me, Friday, was a day that I had of meetings about planning, implementing crisis standards of care. And in those meetings that I had on Friday, April the 3rd, there were people in the room that said, yep, we need to do this right now. We need to put together those teams, the triage teams, the ethical teams within our hospital incident command systems. And there were others in the room that said, no, I don't think at the local level where I work, we're going to get to the need with COVID-19 patients and all the other people we treat, the need for crisis standards of care. But let me just show you briefly what's happened within 7 days. This came out on April the 10th, 7 days after those meetings I had on April the 3rd, where nearly 2,500 long-term care facilities in 36 states are now battling coronavirus cases. We're seeing outbreaks in veterans' homes. We're seeing numbers of our veterans die. We're seeing residents and staff in other long-term care facilities are diagnosed with COVID-19. We're seeing within states like Virginia, where the death toll from long-term care facilities makes up nearly 30% of the total number for the whole entire state. We're seeing where as more testing becomes available, that we're seeing that not only hospitals, long-term care facilities, veterans homes, nursing homes, those crowded areas that where people need to live to provide the care they need, becoming hot zones, very, very high risk areas. No matter what state we look at, we have nursing homes where residents have died due to the COVID-19 outbreak. Again, another veterans home. And again, another veterans home, nursing homes, alternate care, long-term care home, long-term facilities are all on this list. Another nursing home. And what I want to emphasize here, there are ways that we can prepare, plan, implement, even with the limited resources we have throughout the country, to decrease the risk of transmission, to decrease the viral load, to protect the staff as well as protecting the residents. And as we've seen now in Maryland and Virginia, where in just a week from those meetings that I had on April the 3rd, in just a week, they've set up strike teams. They've set up a force multipliers. They've put in teams to battle the viruses in the nursing homes. These task forces consist of volunteers from the community, from veteran organisations, from Medical Reserve Corps, from National Guard, have all been put together as a force multiplier to help deal with the operational needs, the crisis standards of care needs at these long-term facilities. And that's something that should not be just done in 2 states, but every state that we're working in right now. And I just want to finish up with here is some of the references, the crisis standards of care references that I use, the Institute of Medicine reports, as well as selected articles that I use to put together today's presentation. Thank you, everyone. Over to you, Jackie.
Thank you so much. You're always a wealth of information and best practices. We're going to open it up to questions and comments now. And Bill has started us off with a question. Gavin, if you could discuss the differing functions of masks, for example, getting the virus personally versus spreading any possible infection to others.
Yeah, so I want to emphasize, Jack, it's a good question, and it's a question that's coming up on a daily basis. Let's understand infection prevention and control of this virus. Let's understand how we get infected by coronavirus, SARS-CoV-2. And it has to get inside our body. And it gets inside our body through our holes, our eyes, our nose, and our mouth. So when we're doing our own personal risk assessments where we're working, we have to understand whatever mask we're putting, whatever face covering or mask we're putting on our nose and our mouth, or whatever we're putting on our eyes, does it provide, what level of protection does it provide us as an individual? And that depends on the circumstances that we find ourselves in. So much discussion is out there at the moment about putting something is better than nothing. And that's not exactly true in all situations. And I'm getting really worried about this. I'm seeing that there's more awareness of people trying to protect themselves, but they're also using these masks now, Jackie, in situations which are unsafe. They're high risk. And as I see people put on masks, no matter what sort of mask it is, guess what else they do next? They touch their face more because the mask irritate. It's not normal for us to wear a mask or a face covering. So again, there's lots of literature out there I can share with you about the different materials and how and what sort of protection they provide from a virus that's about 0.3 microns or droplets that are even larger. And I'd be more than happy to share that literature. I've got probably about 52 different papers out there that we can summarize that shows what the risks are and what you should be doing from a behavioral and also a way to protect yourself individually from being infected.
Thank you. So let's open it up to questions and comments. Gavin has shared a lot of challenges and strategies and decision-making tools. So feel free to unmute your microphone or in the chat if you have questions or comments. I'll continue to monitor the chat and we'll read those off for those who can't see them. So Gavin, Becky is asking, healthcare workers are both vectors and victims. How do you think about allocating testing for infection in HCW?
It goes down to what's happening locally in the community. Looking at, and again, this is where we need to do better with the numbers. We're seeing some jurisdictions actually map the number of cases they have by neighborhoods, by community. We're seeing some keep it at the zip code level. We're seeing some keep it even higher at the county level. Right now, if we're seeing high viral cases, viral load of cases, a number of patients in the area, we're seeing community transmission, then we need to protect those frontline workers no matter where they are, those essential employees, and we need to ensure that they're tested and that we know what their status are. And then once we test them, Jackie, we need to test them again. And we're not looking at this through the lens of how do we best implement practices that protect the majority Instead, we're still here focusing on the individual. I want to know, do I have COVID-19? Well, whether you know or not depends on what the big picture of what you do. Are you an essential employee? Are you working in a high-risk environment? Does that testing ensure that you can go back to work tomorrow? Or is the testing just something you want to post on Facebook? And we've got to move away from that paradigm.
Thank you. And I skipped ahead of a question. I'm going to go back to one from Karen, and I think this could be open for input from others besides yourself, Gavin, especially if you have this. Karen says she's been struck by the ethical implications of resource management. And what should someone do if they don't have an ethics committee? Is there a place they can look?
Yes, so I teach disaster medicine. And when I teach disaster medicine, my students triage making difficult decisions after any disaster, be it a natural disaster, a man-made disaster, or an infectious disease outbreak. We try not to put the burden on one individual. Now, what that team size or committee size is, it's never been defined, but it's never one individual. And it may not be the frontline physician. It may not be the nurse. It may be someone. It may be a clergyman. It may be someone from the community. It may be business people. But it's people that we actually put together and say, here is the situation. This is the resources that are scarce at the moment. We have 5 patients and 1 ventilator. How do we make that decision? And again, we try to take that burden away from the hospital staff directly, those that are dealing with patients in the ED, the PACU, the OR, wherever they're dealing with them. And we try to bring it back out into our incident command system to either maybe a team of 2, for example, that can actually then sit down, go through the SOFA scores, go through all the other frameworks and the other considerations we make to come up and say, without knowing the identity of the patient, patient number 1, patient number 2, patient number 3, this is what we recommend. And that's the fairest way we can do this. And we do it all the time when I go to earthquakes, hurricanes, for example. That's what we do.
Thank you. Karen, do you have any follow-up to that? Nope. All right. I know we have a lot of people from Penn State Health here, but if there is anyone from other institutions that has anything to add in terms of ethics committees, please feel free to put that into the chat. In the meantime, I'm going to move on. Lex is asking, do we have tests yet for COVID antibodies? Is it possible to determine if someone has recovered from COVID?
And that's one of the biggest gaps, Lex, in our knowledge right now. There's been some assumptions made that when you recover from any infectious disease, you would have IgM, IgG antibodies, and you would have some level of protection. What's interesting for me right now is we look at the number of people that have been infected with COVID-19 throughout the world, the number of people that have recovered. And you and I are still sitting in today saying, do we have antibodies? We don't know. We really don't know. And this is something that I want to emphasize, is that when you have a disaster like this, when you have an infectious disease outbreak like this, the operational research platform has to be deployed at the very same time that we're deploying the critical needs, the treatments, the care. And that hasn't been deployed. When I worked on Ebola, it took us 10 months to deploy the research platform where we needed to find out what the patients were doing after they recovered. 10 months after the outbreak started. Right now, we need a bigger push. We have university professors. We have a lot of subject matter experts that could be working more on these operational questions and needs. And this idea of antibodies and the level of immunity that you have after recovery is still a significant gap. I know many are working on it, and we're still waiting for those results.
Thank you. Other questions or comments? Again, feel free to unmute your microphone. Go ahead, Karen. Thank you.
Gavin, this is amazing work that you're doing, and thank you so much. I feel as if in central Pennsylvania, perhaps we've been a little bit luckier because we were perhaps hopefully a little bit ahead of the curve. We haven't quite seen that surge, but I love that quote that the plan isn't everything, it's the planning and having that done ahead of time. And I think what you showed about the nursing homes not potentially realizing that they were going to be impacted, or whatever the facilities you were speaking with. I'm also struck though, and I wonder in your disaster planning that you talk about the emotional impact that it has on the physicians and the nursing staff and the cleaning staff. In your plans, what would you say for preparing teams after this, or what support should we be thinking about afterwards? Because I do feel that this is an emotional toll. I mean, we hear every day about staff that are going home, but isolating themselves for fear of spreading it. So what would you say for that?
No, I think that's a great question, Karen. And if I can, share with you some of the experiences I've had in disaster medicine when I've gone to disasters all around the world for the last sort of 30 years, we form ourselves into small functional teams. These are teams of maybe 3 people. When I went to Banda Aceh in 2004 with CDC, they set up a system called the External Conscience System. And that's when I had a really bad day, I could get on the satellite phone and talk to someone back in the US that was away from the disaster zone, and I could vent. And they would just listen to me vent, and without any sort of judgment. We're doing the same now for people within hospitals, nursing homes, firemen, law enforcement, forming them into, you might have heard the term the buddy system. That buddy system works in hospitals as you put on and take off your personal protective equipment to watch for breaches of safety, but it also works for emotional support. And I'm really lucky we've all got one of these, and people text me all the time, video conferencing, we're on WhatsApp together, and if someone comes out and says, it just sucks, it really does, that's a trigger for me to say, just tell me what's going on. And it's important that all of us become good listeners, and we understand that people are telling it for a reason, through anxiety, through emotional support. We're dealing with so many worried well every day. People that have underlying comorbidities or underlying medical conditions, or a certain age. My mum and dad, talking to them every day. How can I support you guys? I'm here to listen. So it's every organisation I work with in Karen is that, as well as we have the ways we work, we're now putting ourselves into these teams. And I would say minimum number for a team is 3. It may be 5, but teams, and those teams are there to vent and provide emotional support. And that's part of your incident command system. I make sure that happens all the time.
Thank you.
And the other thing along those lines, Jackie, is coping skills. We don't do enough to help each other with coping skills. And if I can just emphasize that when I teach disaster medicine and I deploy, I would like everyone on my team for deployment to a hurricane, an earthquake, a tsunami, a forest fire, or an infectious disease outbreak, they have at least 2 or 3 coping skills. One of the coping skills I use is I hold my hands up, I pretend it's a camera, and I take a selfie, and I take a selfie of a place where I felt happy. And then I'll take it again. And I'll keep doing it for minutes until I start to feel the anxiety release and I start to feel happy. Or I do another a coping skill that the American Red Cross uses, where I breathe in and I think of a color that makes me happy, and I breathe out and I think of a color that I don't really like. And I continue that breathing exercise of inhaling and exhaling. Breathe in, happy color. Breathe out, color I don't really like. And it could take 10, 15 minutes, but it slows my heart rate down and it starts to make me feel better. And there are many other coping skills that we really should be, even through our just-in-time education, teaching right now to people.
Thank you for sharing those strategies. They go along perfectly with some of the other things that were mentioned by Dr. Joshi on Thursday, I believe. So if you haven't had an opportunity to see that lecture, I think I've watched it twice on YouTube already. He had some really great strategies. Becky, I see you want to contribute.
Thank you for your talk, Gavin. Again, the frameworks that you present are just so useful and connect to so many of the dimensions of what we're all dealing with. One thing I've been thinking about is Kubler-Ross's death and dying framework about the denial, the anger, the bargaining, the acceptance. I think I see those kind of waves of approaches as people begin to have to consider the pandemic in their own world. So as you talk about the nursing home, people in the nursing home that say, it isn't going to happen to me. so that's the denial piece. Or when you first proposed that there was going to be respirator shortages, and everybody shook their head, said, no, that won't happen. So I think that understanding these reactions, both as individuals and as institutions, and to know that we have to move through that or back and forth, I think that can also be a useful framework in trying to help the teams form and maintain. I don't know if you've thought of that, and if people have written about that.
I like that. I like what you just said, Becky, because I've tried to understand what is the challenge, what's the roadblock for people, counting the staff, the space, the stuff, for people developing a framework to start thinking about the triggers and the indicators and the actions to be taken to implement, say, a crisis standards of care, or any other framework we have as university professors that we teach that we think are valuable in a situation like this. And one of the roadblocks I see happening throughout all the hospitals and nursing homes I work in is that we don't want to write the 30-page document. We don't want to take the time to think about the hard questions. We know that we may run out of a critical resource like a ventilator or other personal protective equipment, but you're asking us to do some heavy lifting. And what I'm trying, and I hope as university professors we bring to the table for this emergency response, is the fact that we can take all those thick manuals, those guidelines, those recommendations, and bring them down to a page. This is a page to how to come up and make decisions based on the reality of scarce resources, what you have, what you don't have, and help to simplify that decision-making process. And I think there's wonderful tools out there, Becky, but again, you've got to read 30, 40 pages to understand them. As we as university professors can sit down and say, how do we distill this? How do we digest this down to a one-page tool to help everyone make that plan, and then how to operationalize that plan? And what I see wonderful plans written in all the hospitals and nursing homes I work in, but it's the how. The how is missing, how to make this happen. And when you start talking about the how, everyone goes, oh, here he goes again. That's extra work for us.
Yeah. Well, the map, the Waffle House map felt like an aha moment, that a map just is so much more understandable than a 30-page document. And that was, I could imagine how that could be acted on by a number of people for a number of different uses. So have you thought about what an essential map, actionable map would look like, both for an institution and a region, that would distill these pressure points or key points?
Yeah, so the visualization of everything right now, Becky, I think is lacking. At some local levels, we've seen some fantastic examples of visualization of where patients are, where high-risk people live, where the resources are located. Again, going back to just the Pennsylvania interim guidance for crisis standards of care, they have a map of 154 hospitals. Wouldn't it be great to visualize, if you and I could get on and look at the visualization of what those resources are in those 154 hospitals, and then we see it from, being university professors, we see this from different angles, and we could start actually contributing to the planning, the process, and the decision making, because we see, and when we see numbers, we actually think about them in a different way than maybe other people might do, and we can then contribute actively and positively, and we can help, but we're not seeing those numbers.
So I had a patient with severe asthma who lives up quite several hours from here. And his question was, if I get sick, should I come down to Hershey? And if I had a map like that, I could see instantly what the status of the green, yellow, red of the hospitals near him, and also how Hershey was doing as far as their status in the surge, and be able to direct people, and same with EMTs and a whole variety of people. So I love the idea of that map, of Pennsylvania having a Waffle House map, a COVID Waffle House map. Who would need to do that? I mean, who made that first map, and could they start a color scheme?
Oh, I think this is the perfect segue into universities, university professors, university students helping analyze and crunch the numbers and produce visualizations. That's what we're good at. We're good at teaching. We're good at educating. We understand how adults learn, and I think that's something that we could offer in our services.
Great point. Thank you so much, Becky. They were great points and great follow-up. It's 10:03. I want to give you your Saturday back. If you have any last questions, please put them into the chat. We will follow up. Our next session will be on Monday, April 13th at 9 a.m. Dr. Jamie Pauley will discuss COVID-19 during pregnancy for providers. So if you have a patient case or question on this topic, please let us know. And remember, you can get CMEs for participating today. Watch for the survey. And again, all materials will be shared via email afterwards. Please enjoy the rest of your weekend. Stay safe, and we hope to see you on Monday.